Welcome to another episode of the MEGIN Spotlight Series. Today, we are delighted to welcome Professor Sándor Beniczky. Sándor is a professor in the Department of Neurology at Arhus University Hospital, as well as the head of Clinical Neurophysiology Department at the Danish Epilepsy Center. Hello, Sándor. Thank you for joining us today.
Thank you for the invitation.
So we can begin by asking you, what initially started your interest in MEG, and how has its utilization evolved in your clinical and research career?
Right, so I started with doing EEG as a clinical neurophysiologist, and by that time we didn't have any MEG in Arhus. So I was really envious with all those guys who had the MEG, because in EEG each channel is influenced by the value from the reference electrode, which is not a problem in MEG. And then when you do EEG source analysis, then you have the difficulty with the different conductivities in different tissues, which is not a case for MEG. Although in EEG you can find some workaround, but in MEG this is not an issue. So if roughly 12 years ago we were so lucky to get a MEG, and then this is utilized 50% for research, for mainly cognitive neuroscience, and 50% for clinical applications, mainly in patients with epilepsy or suspected epilepsy.
Can you tell us a bit more about how MEG is incorporated into the operational flow of the Neurophysiology Department at the Danish Epilepsy Center?
Sure. So we have basically two main indications. The most important is for epilepsy surgery, for pre-surgical evaluation of patients with drug-resistant focal epilepsy. And then the other one is for diagnostic reasons. So patients suspected for having epilepsy, but who had normal EEGs. So our routine is that after 3 normal EEGs, including sleep EEG, if we don't get spikes, but we have well-grounded clinical suspicion of epilepsy, then we do a MEG. And we find this quite useful. And obviously for the pre-surgical evaluation, we go for the localization of interictal signals. If we are so lucky to catch a seizure in the MEG, then we do also the ictal analysis, but mainly we do the source imaging of the interictal epileptiform discharges as part of the pre-surgical evaluation.
Thanks for sharing that with us. It's really interesting to hear. So kind of following on from that, what is your experience with the accuracy of MEG source localization compared with other neuroimaging methods?
Right. So we did a systematic prospective study on that. We recorded MEG in parallel with high-density EEG. So we always, unless the head of the patient is too large, so we always record EEG in parallel with the MEG. So we evaluated its accuracy. And then we published that in 2019. The first author is Leonard Wes. We published it in Neurology. This was a large prospective series. So based on this, we concluded that the accuracy of electromagnetic source imaging was similar to the conventional neuroimaging methods, to MRI and PET. So this was between 44 and 57%. So this was similar to the others. Now, then you could ask, if it's similar, then why use MEG? Well, the issue is that this was complementary to the other conventional techniques. So in roughly one third of the patients, we could get non-redundant new information.
Thanks for sharing. So we were interested to learn about your involvement in studying the clinical added value and accuracy of MEG in pre-surgical evaluation. Are you able to elaborate more on this and your findings?
Sure. So as I just mentioned, in roughly 1/3, 34% of the patients, we found this non-redundant information. But then you could ask, yeah, but was that useful? Well, we evaluated that. So we followed up on the decisions, and we had a crossover study. So the multidisciplinary epilepsy surgery team first evaluated all the data, all the modalities, except for the electromagnetic source imaging. Then we made a decision. Then we presented the sources to the multidisciplinary team, and then we looked whether they make a change, and then we followed up on these changes. So, for example, if the change was an implantation, then we found it useful if the implantation showed the irritative or the seizure onset. So, if the multidisciplinary team meeting, the multidisciplinary team already decided implantation, but the MEG induced a new electrode, then we considered it useful only if the new electrode found the irritative zone or the seizure zone. And then in a few cases, the multidisciplinary team decided to skip the implantation. And then, of course, we considered those cases as a useful change if the patient became seizure-free. And then using this evaluation method, we found that in 80% of the cases, the changes were useful.
That's really interesting. So are you able to share how MEG has helped to facilitate epilepsy research conducted by your department?
Sure. So first of all, using MEG, we were able to better understand also the EEG signal. So it helped actually us in understanding better EEG. Then it helped us to develop a method for visualizing the signals in the source space instead of the sensor space. And we have validated that approach as well. It also helped us to optimize the pipeline of the pre-surgical evaluation. So now in all the cases where there is discordance between the basic modalities or the MRI is negative, then we include electromagnetic source imaging too. And it also helped us in the diagnostic evaluation of patients suspected of having epilepsy, because we found in one study that doing MEG adds roughly 18% diagnostic value to the previous 3 EEGs.
And lastly, can you tell us more about your work as the editor-in-chief of Epileptic Disorders? Why is this an organization you choose to collaborate with?
Right. So Epileptic Disorders is the official educational journal of the International League Against Epilepsy. And the second major profile of the journal is clinical practice. And these features are exactly the ones that I'm mainly interested in. So I love teaching, and I'm also concerned very much with improving the clinical standards. So this profile of the journal fits really well with my interests.
Thank you, Sándor, for your time today. This has been very informative for our audience.